We are really thrilled to have Dr. Stewart be our expert for this case conference. So he's a senior investigator in the clinical genetics branch in the Division of Cancer Epidemiology and Genetics at the National Cancer Institute, and he is a clinical geneticist by training. So again, one of his areas of focus scientifically has been DICER1, and it's an area where he is very well published and has published some of the seminal papers. So we're really excited to have Dr. Stewart be here with us and share some of his wisdom and knowledge about DICER1. And then we're excited to have a couple of cases which he can weigh in on after his talk. So Doug, it's all yours.
Okay, great. Well, thank you for the largely true introduction and the opportunity to speak today. I always excited to share what I know about DICER1 syndrome and spread the word on how we can reduce the risk for these children especially, and for families. So as this sort of summary slide shows, the DICER1 syndrome is an autosomal dominant tumor predisposition disorder that arises from a germline defect or a pathogenic or likely pathogenic variant in the microRNA processing gene DICER1. It's the first known disorder to arise from such a gene to our knowledge. And the original description of this was published over 10 years ago now in this paper by my pathology colleague Ashley Hill in Science, in which she did really good old-fashioned linkage analysis in a number of large families that have been collected through a registry, the PPB, Pleuropulmonary Blastoma Registry, over many decades, and found the gene that way. And the figure there shows some of the key findings, key tumors associated with this disorder. The hallmark tumor is the pleuropulmonary blastoma, which we'll go into a little bit more detail later. There are a number of gynecologic tumors, including the Sertoli Leydig cell tumor, gynandroblastoma, as well as the embryonal rhabdomyosarcoma of the cervix. For whatever reason, and when we see rhabdomyosarcoma arising from DICER1 variation, it seems to be only affecting the cervix or nearby structures. Younger children are susceptible to developing a cystic nephroma. There is a cystic nephroma of adulthood that does not seem to be associated with this DICER1 syndrome. Goiter is very common, as is thyroid cancer. And there are a handful of fairly rare for this disorder brain tumors. I list one of them, pineoblastoma, and a non-tumor entity, macrocephaly, an entity that we discovered. I'll have a word about that a little bit later. All right, next slide. So again, this is another sort of summary slide here for you. Restating that this is the first known tumor predisposition arising from a defect in microRNA processing. There's the chromosome location in case you need to take some genetics boards in your near future, and the size of the gene, and some information about some of the molecular biology. Interestingly, tumors, and I use the word neoplasm intentionally because we see this in both benign and malignancies associated with DICER1. They followed the Knudsen two-hit hypothesis with a bit of a twist. So usually it is that somebody has a constitutional germline loss of function germline DICER1 variant, and then they develop a second hit, but it's in one of 5 codons, and they're listed there. And these codons affect the metal binding RNase 3b catalytic domain. And interestingly, this is a sort of a neomorphic change of function or new function that results from this somatic mutation. It is not loss of function. It's thought that 2 loss of function hits in a cell would actually be lethal. So this is a little bit unusual, and it's very useful because, and colleagues of mine are working on this, you can look or potentially look for circulating mutations in these hotspot codons in the blood as a way of tracking disease. And there are some studies looking into that. any event, at the end, you get defective production of mature microRNAs as a result of these mutations, germline and somatic, and that affects regulatory ability of those microRNAs, and as a result, it increases the risk for the development of a variety of neoplasms. Next slide. So I list here both benign and malignant tumors known to be associated in children and adults with the DICER1 syndrome. And by DICER1 syndrome, I mean individuals who carry a germline risk variant in DICER1. So you don't necessarily have to have any manifestations of this. This is somebody who carries a risk allele. We'll just conveniently call them a syndrome, even though they may not show any syndromic features whatsoever or have any tumors at all. And so I list there the more common ones, the pleuropulmonary blastoma, more about that in a minute, thyroid nodules and goiter, probably the most common presentation in this disorder. A couple types of different thyroid carcinoma, some well-developed listed there, as well as poorly differentiated thyroid carcinoma. The female sex cord stromal tumors already mentioned, the cystic nephroma, the rhabdomyosarcoma of the cervix, and then a histologically benign but potentially locally aggressive tumor called a nasal chondromesenchymal hamartoma, which can cause quite a lot of trouble in children and young adults. And then an unusual eye tumor, an ocular medulla epithelioma. Listed on the right are less common tumors that have been reported at least more than once, and should be kept in mind. And certainly if you see any of these, you should think of DICER1 testing in an individual. And at the bottom there, we have a paper in Press reporting possible association with testicular stromal tumors. Next slide, please. So we put together an analysis from our study, which started in 2011, and working with the DICER1, well, the Pleuropulmonary Blastoma / DICER1 Registry, to understand the risk of cancer in individuals who have a germline DICER1 variant. And this was published in Journal of Clinical Oncology in 2019. And this shows a plot of the age of onset through into adulthood of a variety of the more common tumors in this disorder. So you can see pleuropulmonary blastoma and the 3 different types. Again, more on that in a minute. The Sertoli Leydig cell tumor, predominantly developing in childhood, but can extend into adulthood. You can see the oldest cases we have there, women presenting with a Sertoli Leydig cell tumor is into the 60s. You can see the cluster of cystic nephroma in early childhood, but there are a few outliers in early adolescence. You can see thyroid cancer, again, spans in childhood well into adulthood, as does the nasal tumor listed there. And we see the rhabdomyosarcoma of the cervix really exclusively as a more pediatric entity. And there are a variety of other tumors that were found in our cohort, not necessarily associated with DICER1. So next slide, please. So the PPB is the primary driver of morbidity as well as mortality in the DICER1 syndrome, and is the most common primary lung cancer of childhood. So it comes in 3 types. Type 1 is really just in quotes, a cystic lesion, but it has a layer of malignant cells that can, as we'll see, can progress to the type 2 and the type 3, but not always. And the median age of diagnosis of the type 1, usually because of shortness of breath or pneumothorax, or can be found incidentally on a chest film, is around 8 months. So it's quite young. You can see the overall survival is very good. The picture there is literally a textbook picture. It's an enormous cyst. Most of them are not that big, but still present as a cyst in a child. Now, up to about age 7, but typically younger than that, this can progress to either a type 2 or a type 3 PPB. You can see the type 2 is a mixed cystic solid tumor, sarcoma. You can see the median age of diagnosis of 35 months, and the overall survival drops to 71%. And these present with respiratory problems, shortness of breath, weight loss, fever, or a lung opacity. And then type 3 is the solid sarcoma. You can see the median age of diagnosis a little bit over 3 years of age, and the overall survival falls to about 50%, and it presents in a similar fashion to the type 2. Next slide, please. So the good news is that the risks of DICER1, of PPB, as well as other DICER1 associated tumors can be managed. So this slide is normally animated, and it shows the type 1 going to the type 2 in some children, and we're working on analysis where we quantify that. But in perhaps the majority, these cysts, these type 1s, regress for reasons that we don't quite understand, and that forms the type 1R or regress PPB. As you know, you never say never in medicine, but this has very minimal to zero or close to zero malignant potential as a lung cyst. And we've all seen these on individuals of all ages. Some of them are arising because that individual has a DICER1 mutation in the germline. And the majority are asymptomatic. Sometimes they can be big and cause loculated pneumonias or pneumothorax, but for the most part, this is a pretty typical chest CT where they're relatively small and don't cause any problems. But the good news here is that although the PPB is a highly morbid cancer, if not detected in time, it is amenable to screening or I should say surveillance and cure, because there is a limited window of vulnerability, as I said, up to 7 or 8 for the PPB, and for other DICER1 tumors, as we mentioned, the cystic nephroma, it's also quite limited. We have good screening tools in the form of chest CT, and we have good, if invasive, therapy that's curative in the form of a lobectomy. So next slide, please. So for our work with the DICER1 natural history study, the vision we have is the early detection and cure of PPB, as well as other DICER1 associated tumors. And doing this through the identification of DICER1 pathogenic and likely pathogenic variants as soon as possible, as early as possible. And so this surveillance and action can be brought to bear. So what we want to do in the animated version of this slide is to prevent the progression from type 1 to type 3. And so we've developed a multi-pronged approach to do this. And I list them here, and I have a few slides on each one that shows our work and some references. So one is to determine just how common these DICER1 variants are. Another is to understand the penetrance and the risk associated with those DICER1 variants. The third is to develop an understanding of the phenotype associated with DICER1 variation, whether it's tumor or not tumor. To a clinical geneticist, we're interested in all of that, not just the tumors. To formulate surveillance guidelines, and then standardization of how you exactly interpret DICER1 genetic variation. And then at the bottom, that's really more for entirely another talk about what we call genome first approaches to studying this disorder and others. There's increasingly common population scale cohorts, like for example, Geisinger Medical Center, what's being done in the UK Biobank, and others, in which you can identify a variant of interest through exome sequencing, and what exactly do you do with that information? And there's all sorts of exciting possibilities with that. So next slide, please. So the bulk of this work is based on our NIH natural history study, which started recruitment in 2011. And this was a picture I took over 10 years ago after a spring thunderstorm, of the NIH Clinical Center in Bethesda. It's the world's largest research hospital. And unfortunately, off to the right, truncated, is the Bethesda Naval Hospital, the tower of the Bethesda Naval Hospital, which is right across the street from NIH. And you can see the double rainbow there. So we have a sort of a classic rare disease NIH natural history study where we recruit individuals who have DICER1 variation or have a DICER1 associated tumor as a field cohort, and then we in non-pandemic times invite as many as we can to the NIH Clinical Center for an 3-day outpatient evaluation. And for individuals who are carriers of such variation, we do a lung CT if one hasn't been done recently, and collect some skin fiberglass. And then on everybody, both individuals who carry variation as well as family controls, we do a history and physical, we collect labs, we collect pathology material, skin biopsy. As mentioned, we do ultrasounds of the relevant organs at risk, and then they see a variety of medical subspecialists, gynecology, ophthalmology, ENT, endocrinology, and dentistry. So we collect a huge amount of information on the natural history and phenotype of cancer risk of these individuals. So next slide, please. So as I mentioned, one of our first questions was just how common is pathogenic germline variants of DICER1. And working with my postdoctoral fellow, Jung Kim, we just first looked at the data available in the Exome Aggregation Consortium database, which was released a number of years ago now. And if you look at the non-cancer portion of it, i.e. not the germlines contributed by the TCGA study, there's 53,105. And so we developed a fairly straightforward rubric for looking at the variation. Basically, it's loss of function variance. And you can see in the table that in those 53,000, we found a total of 5 alleles, and did some simple math and found that the loss of function prevalence in this sort of collection of exomes, not necessarily a pure population base, but as a large collection of exomes, was about 1 in 10,000, which was much more common than we expected based on how rare PPB is. So next slide, please. And then I mentioned our work with the Geisinger Health System a few moments ago. They're a well-established health system in central and northeastern Pennsylvania, originally founded to serve the miners of that community. And they've teamed up with Regeneron to do population scale exome sequencing. So we have a collaboration with them and did an analysis of over 92,000 people, and we applied, as shown there, a rubric looking for loss of function variation as well as some special missense variation that affecting the hotspots, and found, as you can see there, 12 unique variants in 25 people. And you do the math of 25 variants in 92,000 people, and it's 1 in 3,700. And if you remove the people who are related, because maybe the ascertainment was such that a whole family decided to go in, be a little bit more conservative, it's 1 in 4,600, but still more than twice as common as what we had previously observed in our previous work, and starts to get DICER1 variation into the range of much more common familiar genetic disorders, so much more common than we expected. Next slide, please. And then again, this goes back to our Journal of Clinical Oncology paper from 2 years ago, looking at risk. Again, working with the DICER1 registry, we did a couple of analyses, and this was one where we added up the total number of neoplasms. So this was malignancies as well as the cystic nephroma, not strictly speaking a malignancy, but still clinically very relevant, and did an analysis of just what's the cumulative incidence of these 152 neoplasms in 117 individuals who harbor a germline DICER1 variant. So this is probands and non-probands relatives in the families that we recruited. And you can see in that black line that it reaches 25, 30% by age 10. And you can look at the other colored lines to see the cumulative incidence at a variety for a variety of other tumors. Now, of course, this is a little bit misleading because we were recruiting for people who had such variation. So there's actually a more complicated story here to be told. And if you look at the next slide, that is this is, I think, in some ways the more clinically useful information, which is why don't we remove the probands from this analysis and you just look at the individuals in those families who are not probands. So as part of our study, we do genetic testing in first-degree relatives, so sibs, children, adults, parents, and then moving out to grandparents and cousins and aunts and uncles as extensively as we can. So these were clearly people who were did not present to our study and may or may not even be aware that they have a DICER1 variant. So it's a little bit closer by looking at the non-probands to more of what you may see in the general population. So that, again, this is from our JCO paper, and this is the relevant findings here. The table is from a supplement, but the picture is from the main part of the paper. And they both show the same data, which, as you can see in the table, we've broken this down into males and females. And the age or the likelihood of developing neoplasms, DICER1 associated tumors, plus the cystic nephroma and the nasal tumor by a certain age. So you can see both the risk in boys is actually a little bit higher by age 10 than girls, but overall it's around 5%. And then as time goes on, the risk in females increases greater than that of males until the 60s. And this is driven by the known gynecologic associated tumors, as well as the increased risk for thyroid tumors, which predominantly affect females, whether DICER1 or not. And you can see as we get older, the confidence intervals expand, reflecting less and less certainty, fewer and fewer people in the study. But overall gives you a sense of what type of risk to develop a tumor across the lifespan for an individual who harbors germline variation in DICER1. Next slide, please. And then as another important aspect of our study, as I mentioned, is to look not just at tumor, but also non-tumor phenotypes in DICER1. Again, the idea is how can we best identify individuals at risk? So the top paper there was published in the Journal of Clinical Endocrinology and Metabolism, 2017. We were certainly not the first to describe risk of thyroid cancer in individuals who harbor DICER1, but we did quantify it. And the take-home message is that the risk of a thyroid phenotype, broadly defined, goiter, thyroidectomy, thyroid cancer, was 75% in women by the time of their age 40 years old, and about 20% in men, which is quite notable. And then the second paper listed there, macrocephaly associated with DICER1 syndrome, was again from our study, where anecdotally we had heard of kids who had large heads and couldn't find hats that fit, but also this affected their parents. So again, doing good old clinical genetics work, measuring head circumference, height, arm span, and so forth, we're able to determine that 42% of the individuals for whom we had a head measurement was 42% of individuals who carried a DICER1 germline variant had macrocephaly, and this was well above what family controls showed. And this is of interest, and I have a little screenshot of the Face2Gene app, which is a fairly common app used by many geneticists, in which you can plug in features of interest. And so macrocephaly is on the list now. So if you plug in macrocephaly to this app, DICER1 does come up on the list of differential diagnosis. Now, there are a lot of other things that cause macrocephaly, but at least it gets people thinking about a possibility. And then at the bottom there, we list a number of other papers in which, from our study, we found a modestly higher rate of certain types of congenital renal anomalies, ocular anomalies, some unusual teeth findings, and a paper in Press on testicular stromal tumors, so, Leydig cell, Sertoli cell tumors. Next slide, please. And then this is top two papers are some unusual tumors we found in our cohort or working with collaborators, a teratoid-like neoplasm, as well as a sarcoma of the peritoneum that, as the title suggests, appears like a PPB, looks like a PPB. And then the bottom paper is some guidance on health of gynecologic and reproductive health guidance in people with DICER1 variants. Next slide, please. So practically speaking, you know, when should I think of DICER1? Who do I test? If positive, what do I do next? And we developed these DICER1 surveillance guidelines for DICER1 heterozygotes, and the references there. This came out a couple of years ago. There are some other ones in the literature. This is the one that we put together with the sort of key members of the DICER1 registry. Next slide, please. And this is a table from that paper in which we list things to features, phenotypic features that should prompt one to think about testing for DICER1, obviously with appropriate pre and post-test genetic education and counseling. And not surprisingly, the known associated tumors are listed there, but some other things like lung cysts, goiter, especially at a young age or in males, macrocephaly, as we mentioned, unusual types or undifferentiated sarcoma. And this list seems to keep getting longer and longer. Next slide, please. And then briefly a primer on genetic testing. Who do you test? How do I test? If positive, what do I do next? All these details are in the paper, but ideally you want to test the person in the family who harbors the DICER1 associated tumor or feature, and you want to do germline or blood DICER1 sequencing, ideally with copy number analysis or so-called del-dup, and a lot of the large major testing labs will do this. Somatic or tumor DICER1 sequencing is useful, especially if the germline testing is negative. If the germline testing is negative and you do indeed find tumor-confined DICER1 variants, that suggests that the tumor is sporadic and could be is consistent with a non-inherited case, or it could reflect some low-level mosaicism, both of which are offer some opportunities for genetic counselors to do what they do best, which is explain complicated situations like that to a family and what to do about it. Certainly, if an individual is germline positive, a site-specific genetic variant testing, the variant in that family should be tested in first-degree relatives and then move out. And young children should be prioritized, especially given the risk of PPB and cystic nephroma. And as mentioned, you should rotate out or sort of move out, especially in relatives with young children. And newborns should be tested, by age 4 months to permit the pulmonary surveillance, chest X-ray. Next slide. And again, we go into some details on specifics for surveillance guidelines. I don't want to read all of this, it's in the paper, but for the lung, we recommend a chest X-ray at birth and then every several months until 8 years of age. Also consider doing a chest CT in childhood and at time of diagnosis if it's an older individual. And the thyroid, we recommend imaging by ultrasound by age 8 and then every 3 years, unless there's some physical symptoms or otherwise clinically indicated. And then to consider this, doing this if there's anticipated chemotherapy or radiotherapy for imaging of the thyroid. Next slide, please. We also in this paper spell out some suggestions for surveillance for females. Recommend ultrasound imaging beginning around 8 to 10 years of age and repeating it every 6 to 12 months until at least age 40, keeping in mind that the oldest reported individual in the study, as you saw, was in their 60s. I realize that this is controversial and there's not a lot of data to support this, but these were the recommendations that were developed by the group. Perhaps a little bit more straightforward are the renal recommendations, given the risk for cystic nephroma, and abdominal ultrasound every 6 months until 8 years of age, then every year until 12 years. It's pretty straightforward. And then, you can go to the next slide. Yep. And then as mentioned, there are a variety of more unusual brain tumors, rare brain tumors observed in this entity. There have been some suggestions about doing head MRI as a one-time head MRI. I don't think that's widely embraced, but certainly awareness of the possibility of the development of some of these tumors is merited, and then working up if with symptoms or some sort of clinical concern. Next slide. So I've shown you there how we've quantified prevalence, quantified risk, described some phenotypes, developed some surveillance in a way all towards serving this higher goal of identifying as many people as possible at risk of developing a PPB and the other DICER1 associated tumors. And in the last few slides that I have, I want to briefly describe work of an organization called ClinGen. And then I list in that large box there the genome first approaches, which as I said, is really another lecture unto itself. So just briefly, the ClinGen is, or officially known as the Clinical Genome Resource, is a large collaboration of many people, many institutions. This was a sort of the kickoff paper that was published now over 5 years ago in the New England Journal of Medicine. And its purpose is to create an authoritative central resource that defines the clinical relevance of genes and variants for their use in precision medicine and research. So it really asks fundamental questions. Is a gene associated with a disease? So asks questions of clinical validity. Is the variant causative? Is it pathogenic? And is this information actionable? What do you do with it? And then really tries to promote sharing of variants and of data among collaborators. And if you click to the next slide, one piece of this is something called a variant curation expert panel, a VCEP. Like every organization, ClinGen has its overabundance of acronyms, and this is a little bit of an awkward one, but that's what they're called, a VCEP. And a VCEP is a group of experts who have experience with the interpretation of germline, although increasingly they're getting into somatic too, germline variation in a given gene. And the way this works is a VCEP group is proposed and assembled, and you can see this slide's a little bit dated, but you get a sense there for all the VCEPs that are underway right now. There are now more that are focused on a given gene or a set of genes that increase risk for a certain phenotype. And the goal here is to modify the variant interpretation recommendations that were published in Genetics in 2015, the so-called Richards et al. Paper, which is really a workhorse of a paper on how you interpret germline variation. But obviously, there are 20,000 genes in the genome that we know of, and they're all going to be a little bit different. And the role of these VCEPs is to how you modify those rules to interpret variation. So as you can see in red, we have a DICER1 group, and I work with a number of wonderful colleagues, and we're working away at trying to formulate DICER1 specific variant interpretation guidelines. And it's a process, involves putting together a group of people and developing some classification rules, and then presenting to them what's called the SVI, which is sort of a master body, get some feedback, and then you start piloting them. And ultimately you write a paper that describes your rules. If this is developing a VCEP is of interest to anybody on this call or listening to this call, I'm the co-chair of the Hereditary Cancer Clinical Domain Working Group with Sharon Plon, who's a well-known pediatric cancer geneticist at Baylor. And our responsibility is to help formulate these VCEPs and get them on their way to putting together groups and developing rules and getting papers published on them and moving the work forward. Next slide. Oh, okay, I thought we were at the end. And this is my acknowledgement slide. I'm not going to read this all, but you can see it's like everything in research is a team sport. And I list at the bottom there, if you have a patient with DICER1 or DICER1 associated tumor, and they may be interested in a research study, there's my email, there's the email of the research nurse I work with, an 800 number, and our study website. And we're happy to speak to people or speak to you about it, about participation. The sort of very simple description is we collect as much information as we can about individuals and families, offer free genetic testing, collect materials, and offer visits to the clinical center if people are interested. They don't necessarily have to come to the clinical center if they don't want to. They can remain in the field cohort, and we still learn a tremendous amount from them. And we have an ongoing relationship with them and do follow-up work. It's a longitudinal study. So as problems develop, which we hope that they don't, or new children are born, we collect that information too.